Well, hello everyone, and welcome to another presentation from the Nuclear Medicine Worldwide webinar series, where experts from all over the world share with their experiences and knowledge of the specialty with the Latin American community. This time we have the honor to have with us Dr. Professor Minseok Suh from Korea. And the doctor presentation is Understanding of DOTATOC PET-CT. So we are very happy to have you here, doctor, to share with us all of your experiences. So if you want, I'm gonna make a little introduce of you, of your background. Dr. Minseok Suh is from the Department of Nuclear Medicine from Seoul National University College of Medicine in Korea. His training was at the internship of medicine in the Seoul University, and in the same place he made the residency of nuclear medicine. After that, he started his career as a research assistant, and now on from assistant professor at the Seoul National University Hospital. And he participated in different clinical trials. I put some of them, NETTER-2, PSMA Care, Action 1, and another ones that you are going to have the information in the description of the webinar. So, Dr. Suh, we are very honored to have you here. Thank you very much for this opportunity for Latin America. We are really happy to have you here. So if you want to start, it's okay.
Yeah, hello everyone. Thank you very much for the introduction. Now, I think I can start my presentation now. Okay. Yeah, I hope everyone can see my slides. Yeah. So hello again. Hello to all the Latin America community. So today I will discuss about understanding of DOTATOC PET-CT. I am Dr. Minseok Suh, Associate Professor in Department of Nuclear Medicine at Seoul National University Hospital. So today we will explore the principles of somatostatin receptor imaging and review the gallium-68 DOTATOC PET-CT in neuroendocrine tumors, examine some case studies, and discuss practical considerations such as interpretation guidelines and appropriate use criteria. So to start, what do you think is the somatostatin receptor imaging from these 4 different PET-CT images? So each image corresponds to a different molecular imaging tracer or targets. So to answer, we need to understand the normal biodistribution of somatostatin analog PET tracers. So in somatostatin receptor targeted imaging, significant normal uptake is seen in the pituitary gland, spleen, liver, adrenal glands, and urinary tract. So the spleen typically shows the highest uptake, reflecting its abundance of somatostatin receptor 2 expressing immune cells. And the kidney and urinary bladder light up due to linear expression of the tracer. So understanding these normal biodistribution is crucial for interpreting the somatostatin receptor scan. It helps distinguish normal physiological uptake from potential tumors. So going back, the correct image corresponding to the somatostatin receptor imaging is number 1. And on that image, you can notice the characteristic uptake of the somatostatin expressing rich organs such as spleen, kidneys, and so on. And in contrast, the F-DOPA image in the number 2 would show high uptake in the striatum or tumors with dopamine metabolism. And PSMA PET typically shows a salivary gland, liver, and renal excretion uptake. And choline PET would have a different distribution compared to the other agents. And nextly, there are several different agents now clinically available for somatostatin receptor targeted imaging, such as gallium-68 DOTATOC or DOTATATE, and which is the most widely used agent currently. And copper-64 DOTATATE has also been approved by FDA in 2020. And characteristically, we can acquire the copper image due to its physical half-life image at more delayed time point. So you can see background uptake seems to be lower compared to other gallium-68 agents. Furthermore, it has been known that each agents are known to have somewhat different avidity according to the somatostatin receptor subtypes you can see from the tables. So for instance, like DOTA might show tumor or organs with higher somatostatin receptor 5 expression compared to the other agents. But however, from the articles, it demonstrates that DOTATATE and DOTATOC seem to have no significant difference in the distribution. So any agents can be used with comparable performance according to the clinical availabilities. Next, which tumor type do you think tends to show the highest uptake on gallium DOTATOC PET? Actually, all of these tumors can express somatostatin receptor to some extent, so which might have the highest avidity. So you might need to know how tumors show the somatostatin receptor expressions. So this slide shows that particularly somatostatin receptor 1 or 2 different expression across different neuroendocrine tumors by WHO grade and primary sites. So among the primary sites, usually, generally typical pulmonary carcinoids and pheochromocytoma or paraganglioma have strong expression of somatostatin receptor 2, which may show high uptake in the PET imagings. So all of these tumors, as you will know, these all tumors express somatostatin receptor to some extent, and expression levels can vary depending on the individual patient. So it's difficult to select a single definite answer. Typical lung carcinoid tumors generally show higher DOTATOC uptake compared to other like prostate neuroendocrine tumors, MTC, meningioma, or insulinoma. So what we need to remember is that somatostatin receptor expression can vary depending on the type of the neuroendocrine tumor or the primary sites. Next, this case is a 61-year-old male with a neuroendocrine carcinoma located in the ampulla vata. So he underwent PPPD surgery, then adjuvant chemotherapy with the EP regimen. In the follow-up, image found a new nodule in segment 4 of the liver, raising concern for the metastasis. So what might be the next step for the imaging? So actually, in our case, firstly, DOTATOC PET was performed, but the CT depicted hepatic lesions appear largely normal or only faint uptake in the lesion depicted in the shown in the CT scan. However, FDG PET shows a clear intense uptake in the liver metastasis. So there is a complementary flip-flop phenomenon, which is a relationship between the somatostatin receptor PET and FDG PET in the neuroendocrine tumors. So well-differentiated neuroendocrine lesions typically are somatostatin receptor positive and low FDG avid, while the high-grade transformed lesions often drop somatostatin receptor expression but become highly FDG avid, which shows a very high due to a high glucose metabolism. So next case is a thymic neuroendocrine tumor, grade 2 patient who underwent surgery and perioperative CCRT in the follow-up, a new lung lesion was visualized. So for the differential diagnosis and staging, somatostatin receptor PET was conducted. However, in this case also, the somatostatin receptor PET showed small lung nodule and lymph node with very subtle uptake. And actually, from the biopsy, it turned out to be it has a high-grade NET neuroendocrine tumor with Ki67 level of 55.8%. So, like overall, these cases illustrated that tumor dedifferentiation may have an impact on somatostatin receptor expression and PET imaging. So in such cases, an additional workup with FDG PET might help for the detection of the tumors. So you should be in mind of how the differentiation of the tumors might be. Nextly, here is 4 scenarios are given for patients who had adrenal lesions on the imaging. So what might be the least likely pheochromocytoma? So you can see here an option of adrenal lesion with its SUV and also the normal contra lateral adrenal gland uptake is also written. So you can see very different variable uptake of each lesions here. So you can guess first which might be the least likely. Now, make a guess again with urine metanephrine level and previous history. So actually, the patient had the answer came to be number 1, was diagnosed as adrenal adenoma. Other cases, like number 2 to 4, was confirmed to be pheochromocytoma. So what these cases indicate is that although usually the pheochromocytoma show very high somatostatin receptor expression and high uptake in the PET imagings, it can have variable uptake patterns. And always when you want to make a diagnosis, you always have to consider other serum or urine metanephrine levels or catecholamine levels with the imaging findings. And what might have an impact on these variable uptake is somewhat, there can be different uptake according to the genetic subtypes. So this is an illustration of what kind of imaging agents can be used for the detection of pheochromocytoma or paragangliomas. So traditionally, imaging for these tumors, the MIBG or FDG for metastatic cases has been used. However, recently, DOTATAC or F-DOPA are widely used for the detection of the lesions. So the MIBG scan is classically used. However, recently, PET imaging have been utilized for the sporadic pheochromocytoma. And somatostatin receptor imaging can be used, but the uptake can be variable in such sporadic pheochromocytomas. So F-DOPA imaging may show high value in identification of the lesions. Comparisonly, in a patient with the SDHB-associated mutation, in such cases, in these patients typically show very high somatostatin receptor uptake and often like high FDG uptake compared to the F-DOPA or MIBG uptake. So these imaging agents might be more valuable for the identification of such patients with mutations. So this shows how it can be differ according to the patient genetic mutation. So what we might need to remember is the somatostatin expression can have an impact by the genetic mutation of the patients. And nextly, let's move on to the clinical indication for the somatostatin receptor PET. So among these, what might be the least appropriate indication for the somatostatin receptor PET? So from now, I think we will discuss all of these indications from the next slides. So this is a case of a 58-year-old female, and in the CT, we identified an enhancing mesenteric mass and a small indeterminate liver lesions. So firstly, these were thought to be benign, like such as fibrous mesenteritis or hemangiomas. However, on follow-up, the mesenteric lesion on liver nodules enlarged, and there seemed to have some suspicious enhancement in the small bowel. So for the further workup, DOTATOC PET was done. And as you can see from the image, you can see intense uptake in the mesenteric mass and also multiple liver lesions. And also importantly, PET, we can see in somatostatin receptor uptake in the small intestine. So in such a case, actually not typically matching, but still in patients with neuroendocrine tumors, in such patient with metastasis with a known primary, somatostatin receptor PET can localize the primary site in about 38 to 40% of cases. Next is the 46-year-old male with a pancreatic tail nodule. There was a enhancing nodule in the pancreatic tail, and so the differential diagnosis included a pancreatic neuroendocrine tumor versus an intrapancreatic accessory spleen, which can also appear as a well-enhancing nodule. So in this case, what might be the next step to do? So we have conducted both the spleen SPECT-CT and gallium DOTATOC PET. So the spleen normally shows the most intense uptake on the gallium-68 somatostatin PET receptor PET tracers. So consequently, ectopic splenic tissue can cause false positive uptake on somatostatin receptor PET. Thus, does this somatostatin receptor PET may not discriminate between the accessory spleen and neuroendocrine tumor, although it shows a high focal uptake. So to avoid these kind of misdiagnoses, RBC spleen scan can be done firstly, and if there is no uptake on the spleen, can exclude accessory spleen, and if there is uptake, we can also diagnose a accessory spleen. And if in the negative case, if we subsequently do the somatostatin receptor imaging, we can now differentiate whether it can be a neuroendocrine tumor or other malignancies. So consequently, it might be better choice to conduct a spleen scan in this case, firstly, not the gallium DOTATOC PET-CT. Next is the 76-year-old male with a history of renal cell carcinoma. And there was a new, very hypervascular nodule in the pancreatic head on CT. And so RCC is one of those cancers that can metastasize to the pancreas even many years after the primary. So one possibility is that these pancreatic lesions are metastasis from RCC. And alternatively, they could be a new primary pancreatic neuroendocrine tumor, and which is both are hypervascular on CT. So DOTATOC PET was conducted, and it showed mild diffuse uptake along the pancreas uncinate process. the uptake did not correspond exactly to the CT nodule. Fine, and as you can see from the image, there is some diffuse uptake in the uncinate process. However, there seems to be no exact focal lesion in here. And the final diagnosis after the excision came out to be RCC metastasis for this case. However, as you can see from this case, the pancreatic uncinate process often demonstrate physiologic uptake, physiologic somatostatin tracer uptake due to its high density of somatostatin receptor 2, 3, 5. So these normal uptake can be fairly intense and somewhat ill-defined, which potentially overlapping with a small lesion. So this case underscores a pitfall of relying solely on the SCV or the uptake to the diagnosis of neuroendocrine tumor in such a location might be hard, and it can give some misdiagnosis. So, so some authors have suggested that using a SCV cutoff or head to liver uptake ratio can be helpful for the differentiation of true tumor from the normal uptake. Like SUV higher than 17.1 showed higher accuracy for distinguishing between neuroendocrine tumor and the physiologic uptake. However, it seems not always it works. Still, there can be a significant overlap, as in this case, which turned out to be a pancreatic neuroendocrine tumor with grade 1. So you always have to correlate PET finding with the anatomical imaging in the clinical context. And if there is some matching uptake, you should consider biopsy or further test. So every time if there is a matching uptake, further workup is needed. So it should not be neglected as a normal uncinate process uptake and in such cases. So it should be in a caution for in such tumors in the uncinate process. And switching gears to the reporting guidelines, so for somatostatin receptor PET-CT, this references somatostatin receptor SSTR RODS version 1.0, and this uses a 5-point scale to categorize the findings on the SSTR PET. So the goal is to actually improve the clarity in the interpretation, guide referring clinician on next steps, and help select patient for the PRRT in a consistent way. So as you can see from the slide, the category 1 means which is definitely benign, like example is prostatitis, and 2 is likely benign, like such as example is disc herniations and lesions in vertebral bodies or disc space. But more focus should be done in the 3, category 3, which is the indeterminate. In all these clinical situations, if for these indeterminate lesions, we need some further workups. So like for 3C, there can be somatostatin receptor expressing malignant or benign tumor, which is not a neuroendocrine. In example here is a lobular breast cancer with certain SSTR uptake. So in this case, such further workup is also should be done. And more importantly, in the category 3D, it is a lesion of high likelihood for malignant neuroendocrine lesion. However, with a negative somatostatin receptor uptake. This can be, as we discussed previously, lesions like dedifferentiated neuroendocrine tumors or neuroendocrine tumors with very low SSTR expressions, like prostate cancer of neuroendocrine differentiations, or like such tumors of like insulinoma may have a low some SSTR uptake. So in such case, like as we discussed previously, we like further examination using FDG PET may help for the further differential diagnosis of the disease. And for the 3C, there seem to be some incidental malignant lesions with somatostatin receptor PET uptake, like in the breast and thyroid. So which should be in caution for when we read the PET image. Nextly, the category 4 implies a high likelihood of any neuroendocrine tumor, and 5 is reserved for definitely neuroendocrine tumor lesions. So why I'm showing this is not that we have to follow these point scale system, and it's not mandatory to follow, but what is important is to standardize the reporting form in our own institution in any form. And so when we standardize, we can reduce the ambiguity for the multidisciplinary team in our institutions. And this case is a male patient with rectal neuroendocrine tumor grade 2. The patient had 4 cycles of PRRT, and as you can see here, lesion size changed from 23 millimeter to 30.4 millimeter, and SUV max in the DOTATOC image changed from the 27 to 12. So how would you define the patient response in this case? So the size has been increased, however, the uptake has been decreased. Actually, in such case, we might need to see the response in every aspect. Like we have not only the somatostatin receptor uptake, but also the anatomical imaging. Actually, the patient came out to be a progression on this PRRT. So the salvage therapy was not done for this patient, and other treatment option should be considered for this patient. So what here, actually in this case, what we might need to know is that like sometimes after PRRT or treatment, such a well-differentiated cells which has a high SSTR uptake might be killed after the therapy. But like if less dedifferentiated with low SSTR cells remain, the lesions can enlarge or become necrotic. So in such cases, very mixed signals or mixed response can be seen in the targeted imaging, such as SSTR PET and the anatomical imagings. There has been a report that whether the patient was a responder or not by PERSIST, there was no difference in the progression-free survival, which means that using changes in the SUV on somatostatin receptor PET did not strongly predict who actually stayed progression-free longer. So what we need to remember is when we use this somatostatin receptor PET as a response for the response evaluation, it should be assessed by the disappearance of known lesions or development of new lesions rather than just the change in the uptake or SUVs. So just relying alone on the SSTR PET is risky. So you always have to integrate anatomic imaging to measure the tumor size and evaluate the morphology. And also tumor markers should be always evaluated in the same context to distinguish the tumor response in the treatment. Now, wrapping up with the appropriate use criteria for the SSTR PET, this likely lists scenarios and whether somatostatin receptor PET is recommended or not. And it may tie back to the earlier question on least appropriate indication for the SSTR PET. So, like here, we have seen that it could be used for the diagnosis of metastatic neuroendocrine tumor with unknown primary origin. In such cases, like we can find 40% of near 40% primary lesions in such patients. And if there is a contrast enhancing lesion in the distal pancreas, actually these parts are very hard for the biopsy. So biopsy confirmation is hard in these parts. So we can give some clue for the differential diagnosis of such lesions in the distal pancreas, whether it is a neuroendocrine tumor or not. And also, it has been shown that restaging after completion of PRRT is also helpful. So it has not been discussed in the cases, but assessing somatostatin receptor expression post-therapy can help decide on whether we should go on for further PRRT cycles or switch to other therapy. However, solely using this as a response evaluation can be risky. So other like tumor biomarkers or the imaging, anatomical imaging should be used for the response evaluation. And for the least, actually, these in option 2 might be indeed the least appropriate. And what we can see is furthermore, the NCCN likely aligns with this appropriate use criteria. So after complete resection of the small grade 1 neuroendocrine tumor, like less than 1 centimeter, which has been removed by the EMR, they recommend observation and no further immediate imaging except the routine follow-up. But in a higher, more advanced tumors, the PET imaging can be helpful for in other like very advanced cases. So lastly, as we have discussed, the somatostatin receptor PET is widely used in the neuroendocrine tumors. And however, the SSTR expression can vary by tumor type and the primary location. And SSTR PET is most effective for the well-differentiated neuroendocrine tumor. However, because poorly differentiated NET or neuroendocrine carcinoma lack SSTR expression, FDG PET might be helpful in these cases. And such expression might also differ according to the mutation status. And in the pheochromocytoma or paraganglioma, it has been known that SDHV mutation has high correlation with strong uptake of SSTR. And for the clinical usage of such a SSTR PET, we can use for the differential diagnosis of the lesions. However, always physiologic uptake should be considered in such cases, and more careful should be done in a lesion in locating in the uncinate process of the pancreas head, which has a high physiologic uptake. So always correlating with anatomical imaging is important. And also for the response evaluation, the SSTR expression may change due to the therapy effects or the dedifferentiation. So always combined assessment is important in such cases. Yeah, so this is end of my presentation, and thank you for listening. Thank you very much.
Thank you, Dr. Su, for your time. The topic of your presentation is completely relevant and actual, especially trying to understand what we see in the images and who is going to be the impact of what we see in the chosen therapy for the patient after the PET-CT study. So thank you very much for taking all this time to share your experience in that field with us.
Yes, thank you.
Well, thank you again for your time, for this opportunity, and for sharing your knowledge and have the time to share this time with the Latin American Association of Societies of Biology and Nuclear Medicine. ALASBIM is very happy to have you here. So see you in the next opportunity. Thank you very much.
Yep, thank you very much.
Bye.
Yep.